All right, so we're going to go ahead and cover these next three chapters that are going to be pretty abundant, but pause as you need to go, rewind, because it's going to get a little confusing at times. So just take a little bit of patience and constantly review because, especially for the diuretic chapter. But beyond that, we can do pretty good on the other ones. So let's just get right to it. So we'll be covering lipids, right? So for the most part, whatever notes you guys see that looks like it was written really fast. That's because I was writing that from the time the professor was saying things just to catch whatever she says. So there's three types of lipids, right? Triglycerides, they're the most abundant when it comes to our body. They're actually our primary fuel source. So in our body, we mainly first we use our carbohydrates as energy. Then we use our lipids, which would be our triglycerides. And then once we don't have those, we would go into our muscles, our proteins for energy. Um, Phospholipids happen to be the thing that helps us out to develop our cellular membrane, right? If you guys remember from physiology, we have the phospholipid bilayer. So that's essentially what that's referring to. Not really a fuel source, it's just mainly for that. And then steroids helps us to basically just conduct homeostasis with all the different types of things we have going on in our body. Or that's where they come from specifically for our sterols, right? So usually they end with all, like sterol, like those help out with our steroid production. But the most important ones for this chapter that we really need to know are triglycerides, right? As mentioned, natural fat, they're the most abundant energy fuel source. Most of the time, I want you guys to think of it as this, right? For the most part, our bloodstream, as we show right here, our bloodstream is kind of like our inventory in our body. We have a certain amount of sodium in it, we have a certain amount of calcium, so on and so forth, potassium, magnesium. We learned that in the electrolyte chapter, right? So that's our storage, our primary inventory, where we that's like our back, right? That, oh, let me check the back if I have it. So that is what we primarily get our energy from. When it comes to the to triglycerides, right? Fat is still energy, right? It's just unused energy. We want to have them very close to this main road where we can easily pull from it if needed, right? So that's the reason why a lot of times these triglycerides, they end up building plaque inside of the membrane, right? So we're going to zoom in a little bit to get a better picture. Usually they build up right here on the inside of the vessel, not inside the lumen, right? The lumen is the diameter. It's actually inside of the tissue of the blood vessel. That's where the plaque buildup happens, and then it starts narrowing the artery, and that's how you get the atherosclerosis and how ischemia could develop. So these drugs that we're going to be talking about specifically help with diminishing that as much as possible through a couple different means, right? Here comes our phospholipids, right? So there we go. They're just a little review from earlier. They cover building plasma membrane. That's it. They're the phospholipids. I don't really think this might come up that much because it's such a very negligible thing. And it's not really against high cholesterol, right? Because I mean, itself, it's another type of lipid, not really anything crazy. It's just more just for the membrane. That's it. Uh, Without a doubt, though, if you think about it, a lot of these drugs would affect all these lipids in the end of the day because they're just lipid drugs, right? And these are all types of lipids. There are three types of lipids: our triglycerides, phospholipids, and our steroids. And then this one's just referring to the steroids that they just help out building a lot of different things, right? It's just different. But the most abundant one that we know is our cholesterol, which is, again, one of our steroids. So there it is again. Just keep this in mind. Usually they end with all or sterol, or so those are just talking about lipid-based steroids. Now we're going to get into lipoproteins, and this is actually what is primarily targeted when it comes to these anti-lipid drugs, lipoproteins. So They are, imagine the protein, right, as a, actually we have a little picture here, right? So this right here is an example of a lipoprotein, right? Um, all around it at the shell is a protein, and inside it carries lipids, it carries triglycerides, and it carries cholesterol, right? So that itself is already it's holding in a lot of fat, right? So there's a couple ones, but that carrier, that protein shell that we're talking about, that's called an apoprotein, right? So that's just what it's called. It's just a fancy name. But we're going to go ahead and talk about these three different types of apoproteins, right? Or lipoproteins, to make it a little easier, right? Lipo meaning fat, protein meaning protein. And that's pretty much what they are, right? So a low density protein, right? Or lipoprotein, I should say. Whenever we talk about lipoproteins, I really want everyone to think about the low density. Don't think of the lipid, think of the protein instead. I want you guys to think about that, because when you start looking at this image, right, you'll see it better. But you see how the density on this lipid, or on the protein, right? Well, not really the density, but the diameter of how much protein is available is pretty short in comparison to something like this high density protein, right? Look at that. Look how much protein there is on this high density lipoprotein, this HDL, the good cholesterol, and then look at how little there is on this low density protein, right? So this means that there's not a lot of room of protein, and instead you have all this fat. Look at that. That's a lot of fat. All of that is fat. That's our triglycerides, our phospholipids, and our cholesterols. There are three different types of fat held within this whole chamber. Look at that. That's so much. In comparison to a high density, we have so much protein. Look, all that protein's right here, and then we only have a very little bit amount, right? The LDL, the bad cholesterol, that one was from here to here, right? It was pretty much, it was a lot, but this one has a little bit. So that's generally what it's talking about, right? So whenever we're talking about density, think low, like low density, think low shell, like it's a superficial level shell. And then that means that whatever's in here is all just lipid. It's just a bunch of fats. It's our three different types of lipids that we have that we talked about all the way up here. Um, Right, and that's bad. That's a lot of cholesterol. That's an abundant amount of cholesterol, and usually these LDL proteins, right? They are taken from the liver. So they go from the liver, right? We have the liver, right? Or that's a poorly drawn liver, and they go straight into the bloodstream, right? Because we talked about earlier, usually we want all our fuel, all our different inventory for whatever we need to do our processes, we want them right here so the blood can take them as soon as possible. So LDL, I want you guys to associate LDL with liver to vessels, right? So it starts at the liver and it takes it to the blood vessels. While HDL actually does the opposite, but we're going to talk a little bit about very low density lipoprotein, right? So we talked about how very little there is on a low density lipoprotein, right? There's very little protein in that one. Well, there's even less protein in a very low density lipoprotein. Again, it's all based on of how much protein is there. And look at that. There's so much there's so much lipid here. There's a bunch of lipid, but there's very little protein. And in once this is finished, a very low density lipoprotein, once it deposits its plaque or fat wherever it needs to, it eventually just becomes an LDL, right? So this turns into this eventually, right? Just to kind of give you guys an idea, this just turns into this, and it makes sense because look, very low density, it's still the same low density. Now we can move on to high density, right? So this is reverse cholesterol transport, right? So there's not a lot. There's not a lot of lipid, because look at all that protein. So much protein. And this is now taking it from the blood vessels and it's taking it to the liver to either convert into bile, to deposit it into the stomach, into the intestines, and eventually it gets excreted through defecation. And this lowers your cholesterol. That's why it's referred to as good cholesterol, because again, look how much protein there is, a lot of protein and very little fat. You just need a lot. It's actually preferred to have high levels of high density lipoproteins because they take it from the blood vessel and they put it in the liver, and then the liver usually excretes it out rather than recirculates it back into the bloodstream. While both low density, the very low density and the low density, those just constantly take from the liver to the blood vessels. And look how much fat they have compared to the high density one. Now we could get into our different types of labs, right? Um, One thing I noticed here in patterns is that we have, so total cholesterol is 200, right? The nice thing about these values is that they generally go down by 50 points at each time, right? So for me, look at the total cholesterol, right? I look at how it's supposed to be no more than 200. And then what's below that? Look at this. Serum triglycerides 150. And then after that, LDL, we're not supposed to have it more than 100. And then HDL, generally there's it could be less for men and women, but you want to have more than 60 because that is desirable because we just talked about why HDL is better, or it's actually the only good cholesterol, really. Um, so the way I put it is I made the little in my head the acronym like T and then TT, right? So T for total cholesterol, T for triglycerides, and then LH, TTLH, right? You can make it whatever words you want to put in, but it's TTLH. So as long as you remember what the total cholesterol is at 200, you just work your way backwards, right? So we said total cholesterol 200. Then we go triglycerides go down 50. Look, you can't be more than 150. And then LDL, right? TTLH, right? So LDL cholesterol right here. You can't be more than 100. And then finally HDL. Go with the 50, but remember that it's ideal to have it higher than 60, just because that's preferred. But that helped me remember these values. I don't know how much they'll come up, but it's good to know them. And now we transition to our lifestyle changes. So first and foremost, like we've always talked about in class, we don't really want to have a lot of medication use, right? So lifestyle changes are the most important thing. It's the first like it's the first attempt for a person, especially trying to lower their levels of cholesterol. Um, Obviously, even if they're taking any medication, they should still do lifestyle changes. And generally, I think everyone's kind of aware of this. The exercise plan, reducing trans fats, saturated fats, cholesterol, increase fiber because fiber also helps out with because the fiber husk, right? Like it kind of also absorbs a lot of lipid, right? That's why like a lot of cereals say high source in fiber, and it like Cheerios will have the little heart on it, and it says it will lower your cholesterol because it actually catches a lot of well, not a lot, but it'll catch a good amount of cholesterol and it will help out when it comes to defecating that out instead of absorbing it, right? Um, so that's the thing. So generally, I think everyone's aware. Monitor your levels, maintain weight, right? If your weight goes up, then that means you're having more lipids. If you exercise, it should go down because now you're using more energy. Stay away from fats and cholesterol. Take fiber, and you don't want to smoke, right? Because just a little bit of a reminder, right? So we talked about how in here, right, all this plaque builds up inside our blood vessels, right? That plaque actually hardens the blood vessel. That's why it's called atherosclerosis because it's hardening of the vessel, right? So if you smoke a lot, that will also cause your vessels to constrict and become tighter and less elastic. So if you smoke and you have a lot of plaque buildup, it places you susceptible to possibly an aneurysm because eventually it can burst. So that's why smoking cessation, like always, we always want to tell them, hey, avoid tobacco. But now you kind of can explain a little better why you want to avoid tobacco, right? So these are just different terms, right? We have hyperlipidemia, which is legit just high levels of lipids. It's not very specific, it's just saying there's a high level of lipid. Hypercholesterolemia is more specific about talking about the high levels of cholesterol, right? A dyslipidemia is just abnormal levels. It could be too low, it could be very high. That's abnormal, right? Because we have our normal range. We talked about our normal range, right? We said these are our normal ranges. So if you were to have like a cholesterol level of, let's say, 100, see, usually it's supposed to be like kind of around this, like, generally it's around a little bit lower than 200, probably 150. But if you have like a cholesterol of 50, that's probably a cause of concern. That's a dyslipidemia because that's really out of range compared to kind of the normal. Again, you still need cholesterol. Generally, your body still needs it. However, your body makes cholesterol. It actually doesn't really need to take more cholesterol. But those are just kind of more referring to just why is it abnormal. So dyslipidemia, so the dys is abnormal, it's something's different, and lipids just referring to the lipids. So lipids and cardiovascular disease, right? Genetic and lifestyle contributors are obviously, I don't know why I wrote first choice. I think it's just first cause, right? Because usually a lot of people have generally a lot of issues with, or maybe I was just referring to the lifestyle contributors, but generally a lot of people, I mean, we've kind of seen it in the United States. There's a lot of genetic factors for being overweight, right? And being overweight, the higher you are overweight, the more likelihood you can have a cardiovascular disease such as atherosclerosis, because cardiovascular disease is just an umbrella term for so many different things. But atherosclerosis is one of the different types of cardiovascular disease that fall in there, if I recall right. Right. Most of the time, it's hyperlipidemia, meaning just high levels of fat. It could be our triglycerides, it could be our cholesterol, it could be phospholipids, but mainly it's going to be the triglycerides and the cholesterol, not really the phospholipids that much. Now we're going to transition over to our actual drugs, right? Statins, right? This one is honestly the most kind of important out of all of them because it's the most effective when it comes to actually lowering your levels of lipid in your blood vessels, or in comparison to that too in your blood, right? So these were kind of created a little bit, not very recent, but somewhat recent. So they actually, the statins replaced a lot of the other drugs we're going to talk about because those drugs were not as effective and they had a bit more of a tendency to cause some kind of adverse effect, right? So here we'll get into it, right? So statins, right? The nice thing about all of these statin drugs is that they all end with vastatin at the end of their name. That's awesome. They made that thing super easy to help us out with. Look at that. Atorvastatin, fluvastatin, lovastatin, all this stuff. So, because they're colored in blue, we mainly probably want to pay most attention to atorvastatin, and that's the prototype drug, and simvastatin, which is Zocor. The other ones, again, just catch the part at the end that says Vastatin. The brand name is a little bit beyond me. But the biggest thing is that we're gonna talk about why do you want to constantly watch your patient's liver function test, or not maybe constant, but more than usual, because we're gonna be doing something to the liver. And just like we talked about in the PUD drugs, right? Like PPIs, they specifically turn off cells in the liver. Statins kind of turn off cells or like things that help process in the liver in this case. The PUD one is in the stomach. I'm sorry. The statins one's doing the liver, right? So if you're constantly affecting something that's occurring in the organ, you probably want to check out the organ because sometimes things can occur. Generally, the GI upset is just more referring to a side effect. And it seems like statins, or generally a lot of these different types of these different types of anti-lipidemia drugs are not for pregnancy, which makes sense, or breastfeeding, which makes sense, right? Because you still, like, again, lipids are part of our development. We still need them to actually uh, conduct homeostasis. And as a pregnant woman has a fetus, they need to develop the kid as well, right? Um, and the fetus itself is also developing its organs. So this type of drug could be a drug that's also, like we talked about it, right? We said this affects the liver. So it could also, I'm not sure 100%, but it could affect the liver of the fetus as well. So that's not good. So it's like a double whammy, right? So it could affect the organ development of the fetus, and then it could also just stunt development as well. So that's why you typically wouldn't really use, especially a very potent drug like a statin. But it seems like all these other lipid drugs also aren't really indicated for OB. In fact, they're contraindicated, right? So as we were talking about statins, another name is called HMG CoA reductase inhibitor, which is a very, very fancy term. But if you remember that name, you'll know exactly what is happening in the liver because it's in the name, right? If it has inhibitor at the end, then it's usually going to tell you what it does on the front half. So HMG CoA reductase is a type of special enzyme in the liver that helps out with the processing of lipids. If you turn off a piece of the machine, chances are the machine won't work and it won't take in the lipids like it's supposed to, right? So there it is. I mean, again, it's in the name, and then it reduces serum lipid levels. In terms of the uses and what the term of the goal is, they're pretty easy. It's just lowering your levels of cholesterol. Big things to watch out for. Adverse effects are going to be headache, they're going to be muscle, joint pain, heartburn, and very rarely they cause rhabdomyolysis. So I want everyone watching this to first always associate statins with rhabdomyolysis. And the reason why is because the rhabdo will help us understand certain things at bare minimum the adverse effects that occur when taking statins. So, what rhabdomyolysis is basically your muscles are being broken down to the point where they leak out into kind of like the bloodstream, right? Those proteins in our muscles are really big and they're not supposed to be in our bloodstream. So, as they find themselves in the bloodstream, where does eventually the blood find itself? It usually finds itself in the kidney, right? Our kidney is constantly filtrating blood throughout our entire life. So, those proteins that get thrown into the bloodstream eventually make it to the kidney and cause acute kidney damage to the point where your urine looks extremely dark, like almost kind of black. That's really bad. And there's also, in addition, like lactic acid buildup. Basically, a person is fatigued beyond anything anyone really typically experiences, and that helps, and that causes a lot of different issues. So, what again, to review, rhabdomyolysis, right? Your muscles are breaking down, everything's messing up, and you're causing acute kidney damage, right? So, that if we're having issues with our muscles, will we have issues with our muscles and joint pain? Yes, we would, right? So if we just remember rhabdo, chances are, hey, the patient could have also muscle. Like if this is the worst side effect that could occur, it's not out of the ordinary, and it helps us associate rhabdomyolysis with muscle or joint pain. Also, would you be pretty fatigued, right? Like a person that is working out extremely excessively and they're extremely fatigued and their muscles hurt, right? They're fatigued, right? Headache, right? We could also associate the rhabdo. Where does our blood go? It goes everywhere in the body. It eventually is also going to circulate in our brain. So if you have these toxins that are these like pieces of muscle just circulating in the blood, causing damage in the kidneys, they could also find themselves in the head and start causing things like headaches as well. Now, I'm not sure if that's a direct comparison, But we're just trying to find a domino effect to help us understand all these side effects because there's so much stuff going on. The heartburn, that one's kind of on you because I really kind of had a hard time finding out why, or like trying to make the connection. Which again, it could be just the circulation going through the heart that's just causing issues. But heartburn typically isn't really from the heart; it's more like below, mainly from the stomach. Which actually, well, that kind of makes a little bit more sense, right? Because now if we don't process lipids, because the liver is turned off in a way, it's just collecting in the stomach, which will also help with the different GI issues, right? Look at that, GI upset. So the heartburn is a type of GI upset. So never mind, there's our connection, right? Because we're not processing lipid, we're eventually going to defecate it, but it's also going to build up in our small intestine and then in our large intestine, and then we're going to poop it out. So that's more than likely what it's referring to in the heartburn way. This is just a review of what it is, right? Um, Surprise, surprise, these are our indications, right? So it's to reduce the risk of an MI, and we talked about why, right? Because atherosclerosis will eventually close the artery, right? And then it will cause ischemia, and then the ischemia will cause a heart attack or an MI. That's just what the medical term is for a heart attack. They could also cause a stroke. Again, same thing. It's just in the brain. The atherosclerosis will close off the vessels in the brain. That's it. And then cause ischemia, same way as the heart. Also prevent cardiovascular disease, right? With patients in risk, such as patients who have diabetes, right? We've talked about how diabetes does a number on blood vessels, right? It also makes our blood a little bit more thicker. So that also causes more pressure buildup. And then if they're already smoking, which shows that their vessels are already kind of like constricted, and then if they have hypertension as well, that's just more fuel to the fire into having some kind of bad event occur, right? So it's pretty easy to identify why would you give an anti-lipid drug for these types of situations, right? It's to prevent any ischemia and heart disease. That's all it is. um, I feel like if you were to get that on a question bank, you would probably be able to identify it because that's really all it can do. um, this is just a review of what it's talking about, but it's talking about it a little bit more thoroughly, right? So we said that it shuts down this HMG-CoA reductase, right? That's what helps us process lipids. So if you turn that off, your liver still needs lipids in order to create all these different things, right? They're also if I recall right, the liver also happens to be a big assistant in creating a lot of different hormones, right? So we need these lipids at hand to make lipid based hormones. So, in a response to the lower production that the liver has of not making it any more lipid, they make more LDL receptors in liver cells. So all the LDL that we have in our blood vessels get brought to the liver by HDL. It gets taken from blood vessel to liver, and now it takes it from our supply, right? So if you're not, think of this in an ideal world. You're not eating a lot of high cholesterol foods, you're exercising, so you need the energy, and you're taking a statin. So your intake and production of cholesterol is low, and you're grabbing from your body's resources, your fat, is increasing. So ideally, your cholesterol is dropping. But this drug isn't magic, right? It doesn't cancel out what you eat. In fact, you need a bare minimum of 2 weeks of therapy for the effects to even begin. And even then, you still need to take this constantly for a very long time. It takes several months to really make a full blown 100% dent on patients who have high levels of cholesterol. Because again, we don't live in a perfect world, so this drug isn't magic. Um, and look, there it is. To enhance the therapeutic effects, be on exercise, have a low diet in fat and cholesterol, right? So everyone followed along and understood that, right? So if you're taking a statin, exercising, and have low intake, eventually your levels will drop, right? It won't drop immediately, but they will drop at some point because you aren't making cholesterol anymore. You're not eating as much cholesterol. And where is the cholesterol left in the body? Because we still need to make it. They're in our blood vessels, they're in our adipose tissue, they're in every other place. So your body will take from there and bring it to the liver with the use of our high density lipoproteins, our happy density lipoproteins. Those are our good cholesterol, and from there you'll lower your level. Right? So administration alerts, the nice thing, you can take with food to decrease GI discomfort. Thankfully, a lot of these drugs seem to be kind of leaning on that path, but sometimes they can defer. They can be taken at any time of the day, and we did talk about why they should not be given to pregnant or lactating patients, right? This chicken scratch right here was written off of what the professor said. You know, it needs to be taken 3 to 6 months, just as we mentioned, and because it's a slow acting drug and the patient needs to also exercise, right? Makes sense. Now we're going to go into our adverse effects, right? So big things. We talked about it. This, like how I've been showing off in my past slides, if it has a little box in it and it's part of the same med, chances are this was repeated over. This is just explaining those GI complaints that we can have. And then these are just examples of those GI complaints, right? We have the cramping. Don't forget about the heartburn that comes from earlier. The diarrhea and the constipation is interesting because, well, I guess it goes both ways. Either a person could get constipated or they could have diarrhea. Kind of interesting how that happens. And then there's that hepatotoxicity warning, right? Because again, just like how the PPI drugs can like long-term use can lead to cancer because you're constantly turning off the cells that make acid in the stomach. I'm not saying this will lead to liver cancer, but they will lead to liver damage, right? Because you're turning off cells in the liver, just the same way how we're noticing that constant trend that if you shut down cells of a specific organ, at bare minimum, there will be some kind of damage occurring to it. So it's worth constantly checking, or much more often than normal, checking a person's function tests, right? And then here's that rhabdomyolysis that we're going to use as that building block for us to remember all the other side effects, the much more pertinent ones other than the GI complaints that it seems like every drug has, right? So the rhabdo, the fatigue, the muscle and joint pain, and the headache because of all that stuff occurring in our blood vessels as rhabdo is occurring. Now, again, rhabdo doesn't happen often, but it's possible that we could have a question come up, like a patient exercised very heavily and they look very fatigued, they're super dehydrated, they're super out of it. And, like, would you withhold a statin, right? Especially if the patient is talking about them having cramping, right? That's probably bad. You probably would withhold the statin because that puts them at a higher risk of developing rhabdomyolysis. Contraindications. Clearly, if a person has liver issues, you probably don't want to give them a liver damaging drug, and that goes hand in hand with a lot of other drugs that do damage to the liver, but this one specifically targets the liver. So you want to not probably give it to people who have really bad liver cirrhosis, more than likely, right? Or obviously, like always, they're allergic to the drug. So never forget that. It almost seems like it always comes up. So that's something that's easily rememberable. So drug interactions. So I used my highlights to kind of point out things that are common, right? So the reds, right? So azole antifungals, HIV protease inhibitors, telepravir, um, macrolide antibiotics, cyclosporins, and very uniquely niacin, right? So everything except niacin is all an anti-infective drug, right? I think we can at least recall a little bit from our anti-infective exam. So a lot of these anti-infectives actually put you more at risk for myopathy, right? So that's something that you can make a connection with, right? A lot of different anti-infectives increase the likelihood of myopathy or rhabdomyolysis, right? We're mainly myopathy is muscle damage, Rhabdomyolysis is another type of muscle damage, so we can recall with that. And then niacin is just kind of, that one's a little bit more unique. That's our vitamin B3 or B complex vitamin, right? Um, Ethanol should be avoided because it causes damage to the liver. Surprise, surprise. So obviously don't want to give it. But one of the most important things to know is that this drug, the atorvastatin, which is the prototype drug for all of the statins, they cause digoxin toxicity, right? So digoxin will be a drug we will talk about later in some other video, referring to the heart. So it seems like something about digoxin is possibly made out of lipid, right? So if you reduce the ability to process lipids, that means digoxin will just freely circulate in the bloodstream, and that is what leads us to the toxicity at pretty much at the end. So the biggest things to watch out for: myopathy, rhabdo with anti-infectives, digoxin toxicity, and also maybe oral contraceptives. That's another one. Usually those contraceptives are based off of lipids. And then liver, right? So the two biggest ones to really watch out for that we really need to know, probably the digoxin toxicity and the anti-infectives increasing the chance of some kind of muscle damage. Just two things. This looks scary, but we're narrowing it down to two things. Finally, we have different tests, right? So they're going to increase our CK levels, right? So in association with our kidney, right? If you damage the liver, we're probably going to be damage the kidney somehow, right? It's a fairly strong drug, right? Grapefruit juice. We've been noticing that grapefruit juice has been reoccurring a lot, and it just reaches it. Something about grapefruit juice just prevents absorption of certain drugs, and I guess it just makes it go at higher levels, right? Because if you're not absorbing the drug and processing and metabolizing it, it's staying in your bloodstream longer and it's going to do toxicity. Uh, Very interesting because it's very unique is the red yeast rice, right? And that's kind of interesting because that has natural statins and they increase the effect of atorvastatin, right? So it's like a natural helper to this. So that's pretty unique, right? That's that's fairly unique. So, and statins happen to also mess with the synthesis of coenzyme Q10, right? And that has a lot to do with our energy production in our muscles. That kind of points again to the rhabdomyolysis, right? Or the myopathy that could occur, right? So, it would be good to take these CoQ10 supplements because they help out with energy production. And then in terms of overdose, there's nothing to really help out with. But at least with herbal and food, we're going to finish off with three things, right? Avoid grapefruit juice. Red yeast rice can cause a more additive effect of lowering lipids. And then take CoQ10 supplements because those will help out prevent any myopathy or rhabdo. Right. Now we're gonna go into the bile acids, right? There's two types. There's bile acid sequestrants and bile acid resins, right? So the book is a little bit non-discriminative when it comes to explaining these drugs. They're actually very similar. What I want everyone to really pay attention to is that they all have, if you say it out loud, they all have this very similar name that has coal at the first part or somewhere in the word, right? Look at this: colsevalam, cholestipol, cholesteramaine, right? Look at this: welchol, cholestid, questrin, right? So questrin is a little unique, but we have a little funny saying for it. So if you see any of these words or any of these meds that have coal somewhere in the name, right? COLE or CHOLE. I want you guys to just associate that with bile acid something, whether it's sequestrant, whether it's resin, it doesn't really matter because they're both going to be doing the same thing. What they do is that they kind of hold lipids hostage, right? They sequester them. They're holding them hostage, right? And when you eat food, because these are mainly when you take them with food, um, they help prevent absorption of the acid of fatty acids, right? So lipids. So they hold on to them, and then you eventually excrete them through bowel movement. That's what they're ideally for. Um, Again, now to remember Questrin, right? We like to think because sequestrant kind of sounds like squire, and then for some reason for me, I'm like thinking of like medieval times. So I think Cole the Knight is on a quest to, I don't know, stop the bile acid demon or dragon or whatever the heck. And with that, it helps out. Remember, because Questrin is the only unique one. Because remember, look at this: Wellcole, Colestid, Colestramine, Colest. So it seems like the sequestrants are the ones with COLE, while the resins are CHOLE. But we don't really need to get too fixated on the super, like which one's a resin, which one's sequestrant. Just remember these are colestramine. These are all, they all gonna have some kind of col in the name and what they do, which is just they get rid of bile acids by increasing cholesterol excretion in the stool. That's it. Um, Typical side effects, they're really going to be GI related. A lot of bloating, maybe constipation, maybe diarrhea. A lot of GI stuff. That's really it. They don't really have a lot of crazy systemic effects. They're just more related to the GI. And that's really it when it comes to the bile acid somethings, whether it's sequestrant or resin. Now we're going to talk about niacin, right? So that's our vitamin B3. So this is going to be a little review of our vitamins chapter, right? So it's a B complex vitamin, so it's a water-based vitamin. Niacin, niaspan, right? But it's also called nicotinic acid, right? So what I want everyone to know is that niacin is typically indicated for extremely high levels of VLDL, right? So this drug is specifically for this, right? Super high VLDL. And we talked about what VLDL is, right? Eventually it turns into LDL cholesterol, right? So it's going to help out with LDL and VLDL. What I want people to remember is vitamin B3 is for high VLDL, right? We're going to use the V as a very big thing for us to help us remember it, right? So remember our V, because vitamin B3 will help with high levels of VLDL. So, little fun fact, for the most part, normal dietary intake of vitamin B3, or niacin, or niaspan, nicotinic acid, is generally 25 milligrams. That's our normal dietary intake. In order to have it do an effect on our VLDL levels, you need to take, I think, somewhere between like 2 to 4 grams or 2 or 3 grams of this vitamin. That's an extremely high level of vitamin, right? Remember, like, think about it slowly. We usually need only 25 milligrams for the purposes of lipids, you're using 2 to 3 grams. That's a lot of vitamin. And as we've seen before, the more of the med you take, the more susceptible you are to side effects, right? So, as a little review to our vitamin chapter, you can refer to the grid, but I'm remembering the flushing, right? Because this niacin helps dilate blood vessels, which makes you look very red, right? If you get ready pretty red, you're gonna have hot flashes. You could get nauseous, right? Because if your blood vessels are dilating a little bit, right? Maybe you could get a little, sometimes like a little bit of low blood pressure, which can make you a little nauseous, right? Because it's dilating and you need to compensate a little bit, so your blood pressure could increase, or your heart starts racing a little bit, so it makes you feel a little nauseous. Excess gas buildup, and I'm mainly going to jot that one up just because you're messing with the levels of lipid inside you. Diarrhea, I remember that one from our vitamins chapter. And then hepatotoxicity and gout are possible. And the big thing is that because gout or vitamin B3 makes it actually harder for the kidney to remove uric acid, and uric acid is what makes us have gout because that's hyperuremia. Um, so, kind of something to point out in it seems like generally all these lipid drugs happen to do some kind of damage to the liver, right? Look at that hepatotoxicity, just like how we had over here with the torvastatin, right? So if the drug is doing some kind of effect generally to the liver, they're going to have some kind of hepatotoxicity. Now, I don't think the bile acid sequestrants do that because they don't really go to the liver. They just kind of stay in the GI tract. So it does more GI related problems. But this one, this niacin, didn't really fully explain 100% how does it do it, but it generally does lower your VLDL, which I'm assuming has a lot to do with messing with your liver in some capacity. But just know that it lowers VLDL, and that's why the hepatotoxicity is possible. Now, for the niacin, again, we'll try to come up with some kind of picture to make a connection about the uric acid or gout for niacin. But other than that, we're going to move on to the next one, and there are only really 2 slides, so we're almost done. So, fibric acid agents, right? Now, kind of hate to say this, but we came up with kind of a mean sounding way to remember this, but um, we're gonna call them fat ass agents because FA. Like it's messed up, but that's the only way we're really getting it down. Um, One thing that needs to be caught or noticed is that a lot of these drugs have fib in the middle of their name. There are several different drugs, but they all have fib in the middle. So please be mindful and careful of that. Kind of use your rational side of your head to um, catch that when given a question on a test. Mechanism of action is unknown for the most part, but there is a kind of an idea of what possibly can help out with it. Generally, it's the creation of a type of it helps break down lipids. That's what it is. Our grid that we made and we'll share kind of explains a little bit, but if it says mechanism of action unknown, then it seems like we might not really have to fully like look and scour through everywhere to figure it out. But it okay. So seeing here, it activates a peroxisome that basically just yeah, it affects liver and muscle cells too. It's a kind of similar effect, I guess, as statins, but it seems like it's a little convoluted, so we'll not. It's just generally unknown. Um, Adverse effects, right? GI distress. Watch for bleeding, because I mean, it seems like a lot of these drugs they all have some kind of effect with blood, with anticoagulation meds. So the INR was something that the professor said out loud. She just said, "Watch out, like monitor INR in that case." So she might be referring to I don't know warfarin or something. But in terms of why we said fat ass agents is because it's supposed to treat high levels of triglycerides, right? So, oh, there's the fat ass agent. And you know what? I don't think a lot of people have, but if people have, in the game Grand Theft Auto, they do have the FBI, but they call them the FIB, right? So fat ass agents, FIB, from GTA, from Grand Theft Autos, like the crime games. So we could use that as a way to remember it, right? So maybe a question can come up and it could say something like, oh, the patient is reported to have high levels of triglycerides, but normal levels of cholesterol. What med are they most likely going to get? We would probably lean onto this fibrosol because it's specifically for triglycerides rather than just cholesterol. Maybe a question might come up like that, or maybe it'll be a connection question where you're like forming the patterns, right? Here's all the drugs, and then here's what they do. So maybe it could be that. It could be a matching one. And then finally, our last slide. So cholesterol absorption inhibitor, right? So we did come up with an awesome picture, right? So azetimi, I'm not even going to try that, but it sounds like a Yeti, right? Zeti sounds like Yeti, and it's even in its brand name, Zeti the Yeti, right? So same thing. This one is actually used because it's a cholesterol absorption inhibitor. So it's actually used a lot with statin drugs, right? It's like a helper. It's an assistant to the statin. And all it's doing is just inhibiting the absorption of cholesterol in the small intestine, right? So that's another way to prevent it, right? You're not eating a lot of cholesterol. I mean, it's kind of impossible to avoid all cholesterol throughout your whole life, here, um, how we live, right? But if you take a statin that is shutting off your ability to turn off your cholesterol production, you're eating low levels of cholesterol, right? You're taking, Zeti the Yeti, you're taking that to prevent your absorption, and you're exercising. That's going to help bring all that cholesterol down. Now, what we want to picture is a Yeti usually is in a very cold environment, right? So the Yeti is probably going to have nasopharyngitis, right? They're going to get a upper respiratory infection, right? Or they're going to have a cold, right? Um, then they could, like, right, some people's muscles, which is why we'll have the arthralgia, which is just joint pain, right? Some people, when it's cold, their joints hurt. So we could go with that one. Myalgia. Also, your muscles can hurt because you're constantly trembling and you're cramping up because they hurt, right? Because, like, you guys have been cold before, right? And you're all like constantly trembling. So the constant trembling can cause you to like tense up and then your muscles hurt. And then diarrhea is, I mean, it's diarrhea in the end. If we're not absorbing lipids, they're probably going to come out rushing like crazy. So that's all we really got for all these lipid drugs. I hope it made things a little bit more approachable. It seems like there's a little bit more of a. This one seems, at least in comparison. I hope I'm not overgeneralizing it, but it's a little bit more approachable chapter. It's a little easier than the next ones. The next ones are a little more complicated, but that's it. Um, yeah. All right, so now we're gonna get to chapter 31. So this one is a little bit more of a, not overly complicated, but it's much more abundant in information than the regular the lipid chapter that we were just doing. So bear with me. Pause again when you need to review. Just this video will probably end up being long, like all the other ones. So just heads up on that. Hemostasis, right? So what hemostasis is just referring to the normal. Okay, so we know homeostasis, right? That's just our normal body working like how it's supposed to. Hemostasis is very similar, but instead of, like, homeostasis is referring to our entire body, hemostasis is mainly referring to our blood. So obviously, there are times when we want to clot, right? Like, for instance, this injury right here, right? Would we want to just stay bleeding nonstop? No, we want clotting to occur so blood won't be lost and then we can begin the healing process. Now, there are also times when your body kind of understands to keep blood a little bit thinner. There are times, I mean, I don't know how rare or how current it is, but I am at least aware. I'm sure everyone is aware too, that it clots when it needs to more than anything. That's basically what hemostasis is in regards, like basically holding off and promoting the stoppage of any bleeding. So the clotting process is a very, very complicated process that, thankfully, I believe we don't really need to go into a crazy amount of, but at least there are a couple things that we should be aware of. So the clotting process has several different steps. In fact, it's called a cascade. It's a clotting cascade or a coagulation cascade. So what that cascade is comprised of is, I think, around like 10 to 15 different steps of how the clotting process occurs. And that sounds overwhelming, but again, I don't think we need to really go into every little step. What we really just need to know is that there is clotting factors that are pieces of that puzzle. So we will talk about how anticoagulants stop clotting factors. Some stop clotting factors, some stop it from initiating from the first place, or in the first place, I should say, and some of them will do other different things that stop clotting, right? So there's different effects for it. But generally, right, the blood vessel, when it's injured, it will spasm. It will do this quick little spasms. Those spasms are basically like a signal to platelets freely circulating in our blood, and those platelets get to there, they start attaching, they start aggregating, which aggregation is just what what it's called like in a formal way when it comes to platelets actually like clumping with each other. That's all it means. It's just a fancy term. And then it starts forming once all those factors have created the big clump that starts being made. After that, then a fiber, which is fibrin, funny enough, fibrin starts wrapping around it. Like you guys have probably been, you guys have drove on the freeway. You guys see like a big cargo truck, and it has like a lot of things on the back, right on the back of the bed, and then they probably have like a bunch of straps over it. Imagine the straps as a fibrin, because that fibrin will hold everything together. Because kind of picture it, right? Imagine a stems of grape, like a big stem of a bunch of grapes, right? Imagine that. Picture that in your head. And imagine that is a clot in our blood vessel. And as red blood cells are passing by and other different things that are in the blood, what if they hit that, that grape, the clot, and they start breaking it apart because they're constantly hitting the clot? What we need is something like a fibrin strand to like put it in kind of like a capsule, not really a capsule, but like put it in a net. So if it were to get hit, it doesn't break apart. And that's very big, right? Because if you break a piece of a clot off in, let's say, a big artery, right? The artery was this big and the clot was already kind of like around this big, so half of its diameter. And let's say like a little piece of that clot breaks off and then starts circulating somewhere else, right? We said it happened in an artery. What happens if it goes to an arterial? Then it can block it and then cause ischemia, and then that's where you would have a heart attack like an MI, you could have a stroke, you can have so many different things happen. So the fibrin strand helps reduce the likelihood of the clot breaking off and causing ischemia somewhere else, right? So at that point now it's an embolism, right, instead of a thrombus. But we'll touch on that in a little bit. Normal clotting time is 6 minutes. That's generally it. This is more just talking about the cascade. There's so many different steps that occur in all this, very complicated. But the only one we really kind of need to know from here is factor X, because there's a specific drug that affects factor XA, which I would imagine has to do with factor X. But we'll touch on that later. There's several different pathways to it. There's chemical pathways, there's physical pathways. There's so many different things going on. Luckily, we don't really need to go that crazy in depth about that. That's like something a physiologist would do. Okay, so now that we finished our clot, right? Now, obviously, do we want that clotted forever? We probably don't, right? So within 24 to 48 hours, right? Inside a clot, there we mentioned there's so many different things in the clot. Well, one of the things in the clot is this thing called tissue plasminogen activator, which is TPA. Please keep this TPA in your head because this will play later in a different drug. But TPA is suspended inside the clot itself. We can actually use these little bubbles right here to give us a better idea. These little circles that you see, that's TPA. So TPA is something that is already inside the clot, and that helps out with breaking down the clot, right? So it breaks it down from within. It's not activated until the body, because again, our body's pretty smart, our body knows when to turn it on and when to keep it off, right? Once we know, hey, we're okay, we could get rid of the most of the clot. This TPA, right? Because it's tissue plasminogen, right? Whenever you hear the word plasminogen, or you more specifically, you see the finished suffix ogen or gen. Usually, that's the predecessor to a lot of different things. It could be red blood cell creation. It could be white blood cell creation. It could be tissue creation. Whatever. It doesn't Ogen just is like the predecessor. It's like the blueprint. Think of it that way. And then plasminogen is then converted into plasmin, which then breaks down from the inside out and now the clot is broken, and now we got rid of the clot. There you go. And it's safe. Our body's always doing it, right? Especially like if you scrape yourself, if you break a blood vessel or something. This is ideally what is supposed to happen, right? So that's pretty much it. I did my best to kind of put a couple connections, right? Just to point out plasminogen getting turned into plasmin, right? Um, this drug right here is enhancing the thrombolysis. All this we can refer to as thrombolysis. Thrombo meaning clot, lysis meaning breaking down. That's what we can refer to. So a drug that we will talk about later, alteplase, is a thrombolytic, so it makes this effect occur synthetically. And then there are hemostatics, but we're not really going to talk about those because that's not really a drug we go into, but it helps in the effect of that as well. So it goes in two different ways just because of how it's activated. So diseases that affect hemostasis, right? So thromboembolic disorders, right? So thrombus or embolus, right? Thrombus is static; it doesn't move in the blood vessel; it stays right there. The moment a clot, right, a clot, a thrombus, so on and so forth, the moment that clot breaks off and moves from its origin point throughout the circulation and ends up anywhere else, that is an embolus, right? So to put a real world application, right? One of the biggest worries for a lot of heavy set people or a lot of patients in hospitals is sitting down or lying down for too long of a duration, especially where your feet are kind of hanging down, right? Like if you're on an airplane for a very long time, right, you don't really stand up. So the ability, like what's a condition that causes a lot of clots in your legs? That would be the DVT. Yeah, exactly. So a DVT can break off from down in your legs and find itself in your lungs. What is that called? It's a pulmonary embolism. That's why it's referred to as an embolus because it starts moving from the origin, going through the circulation, and it ends up in the lungs. And now you have a blockage causing an embolism, and now you got a real big problem, right? Thrombocytopenia. So it falls two different ways. It's either not clotting enough, but mainly it's because um, there's not that many platelets in circulation. So, because you've lost all that staff that basically creates clotting, you have a difficulty in the clotting process. And then finally, there's bleeding disorders, which is hemophilia. And I don't think I spelled this right, but I heard it from the professor. She said Willebrand disease. I didn't really look that crazy into it, but maybe it's just something possibly worth looking into. Von Willebrand syndrome or something like that. So Von Willebrand? Oh, Von Willebrand. Oh, well, I didn't look into it that much, so we'll see. So antithrombolytic agents, right? So there are generally three different categories, right? And I want people to understand that there is a big difference in terms of what an anticoagulant does and an antiplatelet does, right? So I want you guys to all kind of picture in your head what it is, kind of consider that in your mind, and then we'll see how it goes from there, right? Um, Generally, an anticoagulant is going to be affecting the actual process of coagulation. It's not really going to be referring to platelets 100% of the time and their ability to reduce the ability to clot is a little bit more predictable than a platelet inhibitor. Because when you use a platelet inhibitor, right, that basically means you're affecting the platelet itself. And when you affect the platelet itself, that causes issues with with the actual clumping process, right? It prevents aggregation. So I just drew this right now, and thankfully it came up. I want you guys to picture the anticoagulant as a message relay, as like kind of the radar message sender, right? This one is calling all the shots, right? Coagulation is typically ran by calling all the shots, right? Platelet inhibitors is directly affecting the platelets. So I want you guys to look at it that way, and hopefully a little picture shows up eventually. Thrombolytics is very simple because they cause just it's breaking down, right? We talked about that already. Alteplase, very similar to human TPA, that tissue plasminogen activator. Same thing, same effect. It's just synthetic. It just breaks down a clot, right? But I really want you guys to focus on these because these are a little bit more complicated just because some people have a difficulty or they have a difficult time understanding the difference between anticoagulant and antiplatelet. So here we go. Here's a picture that I was hoping for. So we can picture this as a platelet, right? I know it's not really a platelet, but it's a platelet. So let's picture that in our heads, right? And then what we're going to go ahead and do as is imagine that a platelet inhibitor, right, is going to do this to it. So you guys see this line right here, right? This line is cutting off these surface receptors, right? Because this little square connects to this little part right here, right? Like we have the male and female portion, right? So that helps perform clumping, right? We have this receptor, and it takes what it needs to bind to, and eventually that just clots together, and it becomes really big, and it forms a clot. Well, if you were to get rid of the surface receptors and receptees, at that point you can't clot anymore because what if you remove this part? You can't attach it to something else. You only have it there, so it's limited. A antiplatelet directly affects the platelet. A platelet can live from somewhere between, if I recall right, somewhere like 5 to 7 days. So a platelet, you're just gonna have to wait for the effect just for the platelet to die basically, and make new platelets that actually have the ability to clot in comparison to an anticoagulant that you can give it to them. You could give a anticoagulant to a patient, they can take it. Like, for instance, heparin lasts 8 to 12 hours. So maybe they can get it super early in the morning. And then once 8 to 12 hours pass, they're actually able to coagulate again. So they could be okay to go into surgery while a person that is taking an antiplatelet has to wait until they make new platelets because those platelets lost the ability to clot. So this could be, it's a little wishy-washy, it's a little teeter-totter. If it was a little unclear, rewatch this segment. But to summarize, right, anticoagulants affect the ability to clot at a signal level, right? If you don't have a signal, you're not getting a good message, so you can't really do it because it's turned off. While a platelet inhibitor actually prevents platelet aggregation directly on a platelet. And if you stop it, then you can't really clot anymore until that platelet passes away and a new platelet replaces it. And then to finish off, thrombolytics, that one is actual active breaking down of a clot. So here it is again. I do want you guys to pay attention to the highlighted colors that I put because that's going to distinguish. There's going to be also color boxes. Those color boxes are not, those are just helping us distinguish amongst different subcategories of these highlighted colors. Again, hemostatics aren't really going to be something we're going to pay attention to. So blue will be our anticoagulants, green will be our antiplatelet, thrombolytics will also be our kind of like violet purple looking color. And then the most important thing, right? A lot of these will have to do with liver function, right? Because our liver has a lot to do with clotting. It works with vitamin K to create clotting factors. So that's where that's going to come in. But also there's going to be, you're going to be seeing this a lot. It's going to be pretty recurrent. There's PLT, INR, and PTT. We'll get into those in as we go through, right? So we're going to first start touching on our anticoagulants, right? Um, First and foremost, there's going to be oral anticoagulants and parenteral anticoagulants. Our parenterals are always going to be typically heparin, right? Heparin. And then we have warfarin, right? So a lot of these anticoagulants generally end with ARIN, right? So arin, right? Either heparin or warfarin. And then there's another one that we'll talk about later. But please be on the lookout for that blue highlighted color because that is all referring to an anticoagulant, right? So heparin is parenteral, warfarin is oral, right? So just right now, off of the top of your head, with our history of all the meds that we've learned, right? If heparin is parenteral, how fast will it work? Probably pretty quickly. What about warfarin? It's a PO med only. Will it work fast? Probably not, right? Will heparin last long? Because it worked fast, but will it last long? Probably not. Warfarin took a time. It took time to work, but will it last longer? Yeah, typically it does. So that's exactly, those are the patterns we want to associate when it comes to the different types of anticoagulants that we have. So big thing with our mechanism of action is going to be that it's just inhibiting the clotting factors that we just talked about earlier to prevent the formation or enlargement of clots. These drugs, for the most part, all of them are not going to be a 100% treatment for actual uh, big clots occurring, right? They're mainly going to be for prevention. They're all related to prophylaxis, right? So they're either going to prevent the clot from occurring or they're going to prevent the clot from getting bigger, because we just want to avoid having some kind of effect occurring where they have ischemia or something, right? And this is just a repeat, but I would also want people to understand there is specific vessels that these types of antithrombolytic drugs, or I'm sorry, antithrombosis drugs do. I want you guys to think anticoagulants are for veins, while antiplatelets are for arteries. That's what they specifically target. They're tailored to those. They can work off label for each other, for both, but they're not ideal. They have a specific purpose. So please please take note of that. Be aware that heparin specifically, heparin, warfarin, the other ones, all the other anticoagulants, specifically they target venous um, clots, while antiplatelet specifically target arterial clots, right? So here's heparin, right? Still part of our anticoagulant, but it's just a blue box, and this will you'll understand why at the end of these anticoagulants, why they're in a green box. I'm sorry. Um, so action, as we've already went with it, right? Heparin, it binds with a specific enzyme, if I recall right. It's just called antithrombin 3, and it enhances the ability to keep clots from either forming or getting bigger. So it's just an enhancer, right? And again, just to emphasize, it has no ability to dissolve existing clots. Again, it's not a thrombolytic, it is just a preventer from getting bigger or making one at all. That's it. We're just gonna move on to the next thing, right? Here it is. There it is. Binding to antithrombin 3 activates that it inactivates, right? Antithrombin. I mean, you could use your words or like you can look at it and break it down. Anti being against, thrombin being clotting, so you're preventing clotting from occurring by shutting off so many different factors. Um, the thing that's nice to remember, IV heparin is immediate, so the anticoagulation effect is legit as soon as you start infusing, while a subcutaneous effect may take about an hour, which kind of makes sense, right? The minute it goes into your blood vessels, it's super fast because it's at the direct site where it needs to be. While when you do a sub-Q injection, it needs to go through the adipose tissue and go through all the stuff and pass the interstitium and then get to the blood vessels and so on. So finally it gets there, and then does its magic. So the big thing to know about heparin, there are different types of heparins. There's two types specifically. There's regular heparin, which is like heparin in its purest form. And that we're going to call that unfractioned heparin, right? Because if you have a fraction of something, it's not the full effect, I guess, right? So there's unfractioned heparin, which is the heparin that we regularly talk about. In fact, I don't really think there's that many trade names for heparin. It's just heparin, really. And then there is low molecular weight heparin. Those are I'm forgetting the generic name, but that is what Lovenox is. It's just a lower based weight of like the purity of the drug. That's it. Enoxaparin, yes. So yeah, so enoxaparin, uh, those that's our low molecular weight heparin, right? So low Venox, which is nice because it has Nox in the name, so it's kind of easier to remember. Um, so again, heparin only really a prophylactic, even though it does say in the slides that there are treatment indications, meaning like you can treat a clot. What I'm mainly kind of getting out of this is that it's only preventing the clot from getting bigger. It can't, again, break it down because it has no real capability for it because you're just only turning off the ability to clot. You're not really piece by piece removing the clot, right? You're just slowly actually just preventing it from getting bigger, right? Um, there's going to be a lot of indications, right? Typically, it's going to be funny enough. Like, it's a little shocking, but even open heart surgery or vascular surgery, they're used to prevent those events. Kind of interesting because you'd think they're under surgery, so you wouldn't probably want to be on a blood thinner, but I guess it is. Dialysis as well, and that was actually explained to me during clinical. A lot of times, when a patient is getting dialysis, right, they have their fistula, and that fistula can actually have a lot of clotting occur because of the amount of blood that is passing through that fistula at the time, right? Sometimes a little bit gets caught, and then it can cause a clot, and then causes a whole big problem. So, pretty interesting to see that a lot of these anti or these blood thinners are all in helping out with not only keeping away an MI or a stroke, but they're also for medical procedures like the dialysis and vascular surgery. So it seems like these are specifically indicated for heparin. There are different indications for other drugs that we will talk about. So we're gonna just move on, right? And then here's that treatment that we were talking about, right? It's given for a confirmed DVT or a pulmonary embolism, but again, it's only given to prevent that embolism from getting bigger or the DVT from getting bigger. That's all it is. Again, it's not going to break it down because there's a different drug for that that actually does that job. Um, for administration alerts, right? Prior to giving IV heparin, there is a weight-based nonogram that is used. Typically, it varies. I think, or not varies, but I think it's standardized in all these hospitals. But what I've been seeing a lot, at least with what the book too also gave me as well, it says that the biggest things you need to watch out for are your APTT and your platelet count. Those are the big ones for heparin specifically. There is a different one for a different drug, but for heparin, at least it's APTT and it's our PLT, our platelet count, right? Um, Another thing too, right? So it seems like for a lot of these anticoagulants, right? A lot of medical procedures given after, like mainly not even medical procedures, just an intervention that a nurse can do, like giving an injection, an IM injection, a sub Q or whatever. Even those can cause problems when being given these very potent these blood thinners, right? Um, it's just saying when you give heparin, don't draw back the syringe, because you can cause some damage, and then don't massage the site because again, that can contribute to bleeding and tissue damage because you're weakening the ability to clot. So, as you guys will go on your clinicals and maybe more, or maybe you've seen this already with experience from your jobs, a lot of older people who are on blood thinners, if you take a look at their arms, a lot of times you'll see a lot of bruises. That's because they're on blood thinners. Even a small tap or a good little hit or something will cause them to have bruising develop, right? And again, that's because of the loss of ability to clot. That's why a lot of bleeding will happen. That's why we're saying don't draw back the syringe, don't massage the site. I mean, even as we go down, there's going to be some drugs where even an injection can cause bleeding that won't stop, like a simple injection. So that is something that we have to be careful about, right? So IM administration, we talked that we can give it sub-Q and we can give it IV. Well, this one is specifically not allowed to go for muscle because of the heavy bleeding risk, right? How many blood vessels do we have in our fat for the most part, right? Like how much? Not a lot, right? If anything, very little. Very little to not a lot in comparison to our muscles, right? Our muscles are very vascular because they use a lot of They use a lot of blood in order to work their magic and use energy. But obviously, it's one way going through the blood vessel directly, but it's another thing too when you're just injecting this medicine through around a lot of other vessels, and then that could cause some damage, right? Because you're already piercing through various vessels because there's so many in the muscles. And now you're doing that, and then you inject it. It does get in the blood circulation, but now you're causing bleeding and occurring internally like that. And that's where problems will arise. So it is pretty much contraindicated to do any IM injections, only SQ and only IV. And it makes sense because you're only really affecting one site rather than multiple. It's a pregnancy category C drug, which makes sense. I mean, not really going to be something that's always often given to pregnant patients, but we'll actually see what there's a slide that actually explains to us which ones can be given for pregnant patients if the need were to show the necessity for it. Um, Adverse effects, right? So the very unique thing about heparin is that heparin causes HIT, which is heparin-induced thrombocytopenia. So HIT actually can, it's right. We talked about thrombocytopenia, right? So uh, there's not that many platelets, right? Because there isn't that many platelets, something about thrombocytopenia causes an opposite effect that can actually lead to thrombolytic events. And I would imagine it's because your body is freaking out because you don't have that many platelets. So it kind of does this paradoxical thing where it actually promotes clotting for whatever you do have for just some reason. It's just something's going haywire. Something in the system isn't working, and it's just that it's causing that. So it can actually cause you to have a stroke or an MI. So it's like the things that we read about, like in our respiratory drugs, right? Remember how there's certain drugs that you give for the lungs, and then they breathe in. Now they're having even worse breathing, right? It's a paradoxical kind of event. So this can be seen that same way because you're giving heparin to prevent blood from clotting, right? Well, some little freak accident can occur and it could actually increase the likelihood of you clotting. And then now think about it too, like, right? So now you're clotting too much and your ability is all out of whack. So that can cause a lot of problems. It's like a whole rabbit hole. So we want to be careful with that. Besides HIT, the only real other adverse effect is just excessive bleeding that can occur from, again, little things. That's why you have to watch out the patient's gums. You have to be careful with nosebleeds. You have to be careful with so many different things. A patient can even bleed internally. You need to be able to identify signs of shock, right? Because if they're bleeding internally, or you can even know, like, oh, they've been defecating blood or dark looking stool, that could be indicative of a internal bleed, right? So those are always the most things to worry about in terms of side effects for these drugs. Um, but heparin is very unique because it has heparin induced thrombocytopenia in addition to the bleeding risk that honestly happens with all these drugs. All of these drugs, you're going to have a bleeding risk because, again, you're affecting the ability to clot in one way or another, right? So drug interactions, right? Um, you guys are going to see this a lot, like given with other anticoagulants or other antiplatelets. Like what? Just even hearing that out loud, what does that mean? You're just going to bleed more. Like that's it. So I'm probably not going to keep repeating that over and over because it's kind of self-explanatory, really. Like, of course, if you take one anticoagulant and then merge it with another anticoagulant and then take it with the antiplatelet, you're just going to make bleeding worse, right? The thing that's better to watch out with is drugs like nicotine, digoxin, tetracyclines, so our anti-infectives, and antihistamines prevent the effect of the drug, right? They inhibit anticoagulation. So nicotine, digoxin, tetracyclines, antihistamines, these are basically reversers. Like they reverse the drug or they cancel out the drug. That's something a little bit um, more unique or something that's actually important because this blue and green highlight, again, it makes sense because it's self-explanatory. but the red is very unique. So that's why I highlighted that one in red, because it's a little more unique and more, it stands out more, right? Um, for laboratory tests, right? We need to watch out with AST, ALT. That makes sense again because I just jotted back that we're messing with the liver, right? You're messing with the ability to clot because the liver is what helps us clot. And our liver might be thinking, hey, something's wrong, so let's make more of whatever, cells are needed for or I'm sorry, clotting production, right? And that basically brings up our enzymes up. That's how I'm picturing it. It's the same way how I pictured how PPIs will shut off your stomach cells, right, from making acid, and then from there you could lead to cancer, right? So maybe that's something that you want to be careful with. Not saying that blood thinners will cause that, but they will cause some kind of the liver will respond one way, right? If you use a drug to affect an organ, it's obvious that your entire body will identify that change and try to address that change in some kind of manner, right? Does your body know 100% you're taking the drug to prevent clotting? No, it's just identifying, hey, I'm not clotting, so I need to make more. Um, Now we're going to finish up right here. So I want everyone to pay attention to this yellow highlight because honestly, for all of these blood thinners, you have to avoid the 4Gs and the F: ginger, garlic, green tea, ginkgo, and feverfew. That's universal for all of these drugs. So I'm only going to really say it on this one and then just say, hey, look, it's a reminder from the first slide because that's for all of them. For some reason, these 4Gs and the F, 5 for feverfew, will they just create more of an anticoagulant effect, so they cause for more bleeding. And then the nice thing is that there is a treatment for overdose, and that is protamine sulfate. And it's given IV, which makes sense because you want to go directly into the blood vessel to reverse all that overdose from way too much anti-clotting. And the dosage is 1 milligram per every 100 units of heparin, which I mean, shoot, we've seen how much heparin could be dosed at. It could be like 5,000 units. So it could be a pretty big dose, right? But I'd imagine it gets infused slowly. I can't say for sure because I've never really seen that drug, but um, that's just something interesting about that. And then the nice thing too is that, right, heparin, we said heparin is one type of heparin, right? What did we say is another type of heparin? Look at that, our low molecular weight heparin. So this would work for enoxaparin, which is our Lovenox, right? Because Lovenox is just mini heparin, if we want to call it that. But funny enough, when we go around to it, we'll talk about a little bit more like something interesting of why is there even a thing as enoxaparin. Oh, which look, there it is. There's a slide. So the reason why enoxaparin pulls up is because even though it's a lower molecular weight, I guess we could look at it as like because it's lower, it's a little hard, like it's a little sneakier, like it's a little harder to get around. So heparin has a duration of about 8 to 12 hours, right? Well, enoxaparin, if I recall right, has a bit of a longer duration. So it's a little bit, it has kind of more of an extended work. So maybe instead of 12 hours, maybe it's 18 hours. Maybe it's 14. That part I'm not too sure on, but it works longer than regular heparin because, sometimes like the little versions of things they work a little bit more efficient because they have less energy, right? I mean, to kind of put in real life, in a real life effect, right? Like the older fridges in the past are smaller and they have less parts, and then now newer fridges now they have more parts and they're bigger, but they don't work as good as the old ones, right? So that's kind of how I'm approaching these lower molecular weight heparins, right? Same thing, they're given subcutaneous because obviously you're not going to give it through muscle because you're breaking too many blood vessels at that point. um, no real need for a crazy lab marker, but you still want to watch out for general bleeding factors and lab values. That's basically meaning, I would imagine, PTT and PLT, right? Because that's what's helping us out with that. Low dose DVT prevention makes sense because we already talked about that's what heparin is used for regularly. So Lovenox is the same thing. And high dosages is a little different compared to the other things heparin does, because high dosages of Lovenox treat atrial fibrillation, STEMI, pulmonary embolism, and there's DVT again, but I would imagine like a much more extreme DVT. So pulmonary embolism we kind of talked about already on the other one. DVT we already did, but atrial fibrillation and STEMI, they're both a little bit more unique. So that's something that stands out. Maybe a question will come up and say like, "Hey, the patient is having a STEMI. What possible anticoagulants can they get?" And that then we can talk about, oh well, maybe they're getting a Lovenox, or maybe later, if I'm correct, they'll get Ciplitogrel or something. Maybe that's what will happen. So we'll 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 touch that. We'll touch base on that when we get there, right? So now we have warfarin, right? That one is our PO version of an anticoagulant, right? Coumadin. So um, generally, this one is a vitamin K antagonist, right? We talked about how vitamin K helps us clot, vitamin clotting. That's basically what it is, right? So if you hold off vitamin K, and if vitamin K is very important for clotting, if you hold it off, you won't be able to clot. The big thing that needs to be understood is that it takes time for it to work, right? We talked about that earlier, right? It's a PO drug, but it still takes time to affect the amount of vitamins, because remember, vitamin K is a lipid soluble drug, right? If we remember from the fluids and electrolyte chapter, we actually store lipid soluble drugs in comparison to water soluble drugs that we constantly urinate out. So if we have an abundance, we have a storage, we have an inventory of a lipid soluble drug, then if you're going to use an antagonist, it needs to work its way into actually stopping it. Which, funny enough, warfarin is typically used at the same time as um, heparin, because if a patient needs to be on warfarin for a long-term treatment, well, obviously we don't want to withhold them from having any from having clotting, right? We want to have them clot as soon as or anti-clotting as soon as possible, right? So we want to prevent that from occurring. So we want to have the immediate effect, which is heparin. Like heparin will work instantly, right? Like we talked about. And we also want to then give the warfarin so the warfarin can later do its job. So that's why they're used typically at the same time. So maybe a question could come up and say, the patient is going to get some kind of anti-clotting or anticoagulant treatment for future or long-term treatment, right? So then they're probably going to get the heparin to begin at like the anti-clotting process just off the bat, and then when will the patient be on warfarin? Like the patient says, oh, is this the only med I need? And then you could probably be telling them like, oh no, you're also going to be taking a pill, but it just needs time to catch up. That's a possible question that could come up, like in patient education. um, Indications, right? Prevention of stroke, MI, DVT, PE. Those are kind of reoccurring. A lot of these are going to be preventing those. So those are like a common reoccurring trend. And you don't really need to memorize them. You just need to identify them when the question comes up, if the question comes up for these, right? Because a stroke can have an origin of a clot, right? And MI the same way. DVT, it's in the name. Pulmonary embolism, again, it's coming from DVT, so it's in the name. Um, in terms of medical procedures, there are long-term use of CVCs, which is central venous catheters, right? So your central lines, if I recall, that's the same. If it's the same thing, but it might not be, or prosthetic heart valves, right? Um, Usually, prosthetics in the body, especially in the heart, like stents, a lot of clotting occurs because the body notices that it's a foreign agent, like it's not from our own body, and it kind of freaks out and it doesn't know what it is, which makes sense because it's foreign, and it starts kind of clotting up that area. So usually you would use a blood thinner in order to prevent clotting from occurring, because after all, the stent was placed there, for instance, or the valves were there placed, for you to bleed better, or I mean not bleed for, but like have circulation better. So if you were to have those things like those foreign pieces of equipment in the heart might freak out and not know what it is, and then start attacking itself in a way. I guess it's not really attacking itself, but it can then lead to ischemia, which then becomes a heart attack, right? There's MI again, there's AFib, and those are reoccurring. So a lot of these are very reoccurring to MI prevention, AFib, MI treatment, stroke prevention, so on. So this is just a review. Warfarin can take several days to reach its maximum effect, and then that's why warfarin and heparin are used at the same time, which we talked about already. So this is just more uh, kind of a callback, right? Um, the biggest lab result to really watch out with warfarin, and it is very important to know, is INR. INR is the international normalized ratio, which is very, very broad. It's not super clear 100%, but I'm imagining that's kind of like a peak and trough. I would imagine it's a peak and trough because they're constantly talking about how you need to watch your patient's INR because if their INR is too low, then they have the ability to clot now. But if their INR is way too high, now that puts them way too susceptible into bleeding. So I'm imagining that's probably what they mean by that. So very similar to like our vancomycin, right? The way I used to remember warfarin with INR, right? I imagine when it comes to war, I'm a little familiar, at least with like people they've used drones, right? They call the footage that drones make, they call that ISR, so that sounds similar to INR, warfarin, war drone, INR, ISR. That kind of makes my head kind of connect that. Coumadin, I guess combat, sort of in a way. I guess it's something to kind of bridge the gap at least. It helps me. Maybe it can help you, but if you can find a better way to do it, by all means. So administration alerts, right? Life-threatening bleeding can occur. I mean, it can occur again if given IM or even subcutaneous injections, right? So mainly the IM. Well, IM can. Let's not go into that. It's just talking about more how you treat the OD treatment, which is just giving vitamin K. Sorry, I went through that a little quickly. But yeah, how do you reverse it? I mean, if this is a vitamin K antagonist, you probably just want to give a lot of vitamin K. That's really kind of how you give the solution. It's like later when we're going to talk about our diuretics. If the patient loses too much fluid, how do you fix it? You just give fluids. So if you removed a lot of vitamin K, you just give more vitamin K, but you give it by IM or IV. But typically, you're probably going to give it by IV because you need it like fast. It's a pregnancy category X, right? This one is not given. The reason why would be, again, it's fetal death. So we'll, again, not ideal, not ideal, not very ideal. So now we can go down a little bit, right? Adverse effects, abnormal bleeding that can go on for 10 days, right? That's really it. Again, we talked about that. Causes bleeding a lot and everywhere for all these drugs, right? What's unique again, heparin is a hit and abnormal bleeding, and then this one's just abnormal bleeding. Black box warning, major fatal bleeding. This is why it's constantly needing to check INR. Again, so we could look at it as our peaks and troughs. And then we can just move on. And here's the part that gets a little bit more complicated, right? So, big things: herbal and food. Look at that: green tea, ginkgo, feverfew, garlic, ginger. The 4 Gs and F, we already have that. The only unique one is cranberry and chamomile. So one way we can kind of remember that is there's C in coumadin, C in cranberry and chamomile. Kind of the best way we can bridge that knowledge gap a little bit, right? If the patient, right, if the patient is getting this vitamin K antagonist activity, what would you probably want the patient to avoid? Perhaps sometimes you probably want to avoid foods that are very rich in vitamin K, like possibly, or at times you can that could actually be referred. It's just case by case, I guess. It just depends how badly the patient needs to be on the blood thinner to have its full effect, right? But it makes sense that if you take more vitamin K, right? Imagine we're at the same level here, right? So here's the amount of drug we have and the amount of vitamin K we have, right? If we have more vitamin K, will it drown out the drug, it will, and you'll lose the ability, like it diminishes the effect. It kind of makes sense, right? So that's why sometimes I am aware that there are like certain doctors who are like, okay, well, you might want to like take a little bit more vitamin K foods, just a little bit, just to like prevent heavy blood loss. But again, it's wishy-washy. Sometimes some people might be told, hey, you might want to be careful taking how much food. Just really be aware that if you eat foods that are very vitamin K rich, they can reverse the effect of the vitamin K antagonist. Surprise, surprise, right? So to help you remember vitamin K rich foods, really think of foods that you can kind of like peel off little by little, right? So a Brussels sprout, right? It's like a little cabbage, right? You can peel it off and like you can keep the leaves, you can remove the leaves little, little, little until like it turns into like a little ball, right? Cabbage is the same way. You could do that too. Um, broccoli, and even cauliflower. Those are vitamin K rich foods. They're called cruciferous foods. That's or vegetables. That's what they're called. So if you can identify those, like specifically the cauliflower, the cabbage, the Brussels sprouts, the broccoli, those are the main foods that we want to kind of put our heads when we think of vitamin K rich foods. Treatment of overdose, we just talked about it, right? It's either you're going to give PO vitamin K if it's not an emergency, or you're going to give IV in an emergency, right? Because you want to reverse the effect of anticoagulation. And in addition to that, you also give prothrombin complex concentrate, which is Kcentra, right? A way we can remember the name is, right? So um, it's vitamin K in the end. We need vitamin K, right? So K is already in there, and then concentrate, right? Kcentra. So we need Kcentra for a person who is lacking vitamin K in the context of anticoagulation. Like we need to undo their overdose, right? So Kcentra, prothrombin complex concentrate, and intravenous vitamin K. And then here's that role of the nurse. This is why the color boxes are very important, right? Um, because this is like a review for everything, right? You want to monitor CBC, makes sense. Lumbar pain is very important because lumbar pain could be indicative, especially like after a like lumbar procedure or some kind of thing. It could refer to bleeding in the spinal cord, right? And if there's bleeding that occurs in the spinal cord, blood can accumulate and then eventually push on the spinal cord, and then now you have paralysis. That could be permanent or it could be temporary, right? But it's a possibility. So that's where the lumbar pain comes in. Abdominal bulging is like heavy internal bleeding, so that's one that you can also be careful with. And then guaiac tests on stool, that's specifically testing for for any presence of blood. So guaiac, you might want to associate that with blood tests, right? So maybe you can have like a question like, oh, a patient was in the ED for possible internal bleeding. What are some labs that can be drawn, right? So probably your CBC, probably your PLT, your APTT, and then a guaiac test perhaps. That's like some possible tests that we can see. Um, right? And then this is again where little boxes come in, right? So the purple was about warfarin, the green was heparin, and the low molecular weight was that enoxaparin, the Lovenox, right? So heparin or heparins can be given to patients who are pregnant if the need be. But things like warfarin cannot be given um, to pregnant patients, and it makes sense, right? Because you're antagonizing vitamin K. I would imagine a fetus that's developing, right? They need all the vitamins they can. After all, they have the prenatals and everything, right? So if you're using something that's directly like stopping vitamin K, one of like many necessary vitamins, that's where the fetal death comes in, right? Heparin and the lower molecular weight heparin, otherwise known as enoxaparin, the Lovenox, those don't do that. So these are okay, obviously. Do you really want them to be on it? Probably not, but if the need be, if it's that necessary, yes. And then this is just that last reminder of, be careful with garlic, which we talked about is one of the 4 Gs. And that's it. Now we're going to move on to our antiplatelet drugs, right? So somewhat halfway through, but not quite fully there. But antiplatelet, again, we talked about it. We're affecting the ability to actually aggregate amongst the platelets. It's generally pretty clear. It's used to prevent any thrombi formation after a stroke or MI, right? So this is kind of more of a long-term drug, typically. So you'll see a lot of older people taking it. And then we're going to have our example, right? So here's Saplicogrel, right? Plavix. So for this one, again, it reduces the rate of another MI or stroke. And then there's also patients that have had a STEMI. So a STEMI is just a fancy name for like something that causes an MI, like the myocardial infarction, because it's acute ST elevation myocardial infarction. You'll kind of go about, if you're familiar with EKGs, you'll know what that is. But long story short, it's just a different type of heart attack. It's a type of heart attack. There's also non-STEMIs, right? And that's again another type of heart attack. It's just on a different area in the heart. Unstable angina, which is associated with heart attacks because angina is chest pain. Coronary bypass procedures, or PCI, which is another heart-related procedure. So a lot of heart-related procedures on this one directly, just like the other ones, right? Pretty interesting. I would have thought that those were kind of dangerous, but I guess they are allowed for that, right? It is off-label, right? Because we said, what did we say? Antiplatelets target what vessels? They target the arteries, right? But it could be given off label, like we said earlier. For DVTs, it's just not the first go drug, right? If it says off label, that's like, hey, we're tossing the coin in the air and maybe it might work, maybe it might not, right? And then also off label for stents and just prevention of thrombi formation for those people with stents in the DVT. So pretty interesting stuff. This is just referring to its actual mechanism of action. It's directly inhibiting an ADP binding. That's part of our adenosine diphosphate process for energy. I guess something about with ADP on a platelet allows for clotting to occur, but if you are directly inhibiting it, right, you're killing off that part of the platelet. Now you can't clump together anymore, and then now you can't form like a clot. But you just need to be careful because again, this one, once it's affected the clot, it's with the clot for the rest of the clot's life. So again, that's why a clot can, or I'm sorry, not a clot, platelet. So it's there for the rest of the platelet's life, right? Platelet again lasts 5 to 7 days, and then it passes away, and then we make a new one. So that's the reason why this drug should be discontinued at the bare minimum 5 days prior to surgery. Um, do not crush or split these drugs, right? Here's our adverse effects. Flu-like syndrome, headache, dizziness, bruising, rash, pruritus, and then bleeding, obviously, right? So we're not going to go too much into the bleeding one. So one way we kind of wanted to go, like, whoa, that's kind of a very unique set of side effects for this drug. We kind of made a mental image in our head, right? And we'll probably put it up once we're finished with our grid regarding the how to make the connections of Plavix with these really interesting side effects of flu-like syndrome, headache, dizziness, and all that. So just like we did with our anti-infectives, the antibiotics, we use tetracycline, right? And we called the little kid riding the bike, we called him chlamydia, right? So we're gonna do that too. We're gonna picture a girl that is at the park, right? And she fell and dizzy now, and she got the whole bruising thing going on, or like a rash because she scraped her head, right? The flu-like syndrome is a little bit more up in the air. I guess like maybe we could picture like a kid sick with the flu in the background. Maybe that can help. But the headache, dizziness, at least we can make that connection. All right, so here are drug interactions, right? We already talked about it. Anticoagulants, antiplatelets, other NSAIDs will cause more bleeding. Surprise, surprise. Barbiturates, rifampin, and carbamazepine, those make more of an effect, so they kind of fall under the same increased risk of bleeding. And I guess it's just because it shuts down your body's ability to process these drugs, right? We're kind of inhibiting the liver from really working or metabolizing it, so they stay in the blood longer, right? So they have more of an effect. They can lead to more toxicity. So there's that. Um, Kind of interesting on this one though, right? Azole antifungals, protease inhibitors, erythromycin. A lot of these drugs, including PPIs, they all diminish the effects of saproptegal. So maybe we can kind of picture that this like the same way with the kid in the background that has the flu, right? They're taking their medications and now they're not bleeding as much, right? Like or a kid in the background that also got hurt, right? Because they're taking their medications for all these anti-infectives. This one's for asthma, this one's for GERD, right? So now they don't bleed as much because look, the antiplatelet effect is gone from saproptegal because it cancels it out, right? So the yellow down here is referring to canceling out the effect of the drug, while up here, this upper half portion is referring to increasing the risk of bleeding with obviously anticoagulants, platelets, antiplatelets, NSAIDs, right? Because we said aspirin is an NSAID that can lead to blood loss too, because it works as an antiplatelet. And then this barbiturates, rifampin, and carbamazepine. Um, We already talked about the four G's, but an extra one is fish oil. So in the picture in our heads, we can say that they were at the park and they were doing a cookout and they were cooking fish to help us remember to stay away from fish oil because fish oil increases the risk of bleeding, right? And then platelet infusions are given to patients who are having hemorrhage. Makes sense because their platelets are gone, right? So just give them more platelets, right, through infusion. And that's it for the antiplatelet. Now we're kind of close to finishing. So we got our thrombolytics, right? So thrombolytics is our alteplase, right? And this is where I want you guys to remember about TPA, that tissue plasminogen activator, right? This is what's working right there. Thrombolytics. I want you guys to picture thrombolytics and put it at the same level as albuterol. Albuterol is a rescue drug, right? It's our first line treatment for a person having bronchoconstriction. Thrombolytics are a rescue drug for people who are ongoing, like actively having a blood clot in their brain or a heart attack, an MI. So these are given specifically. They should be given these, but they need to meet a specific time range within them, right? So there it is, treating acute MIs, deep vein thrombosis, right? Things that can actually full on like can even kill somebody, right? Because the deep vein thrombosis can cause a PE. Have we been noticing a pattern? All of these help with deep vein thrombosis, really, right? So that it's kind of a general statement. I don't think they would test heavily on that. It's because they all do that, right? But they do treat that CVA that we were talking about, active PEs, arterial thrombosis as well, right? So this is a rescue drug, right? And off label, it helps clear IV catheters, which makes sense because sometimes blood does get stuck in IV catheters, so you need to flush that out, and that's one way that you can do it, right? Because it breaks things down. Because after all, these thrombolytics, right? Thrombo meaning clot, lytic meaning breaking down. So here it is, alteplase activase, right? We can remember the trade name because alteplase is very similar to TPA, which is that tissue plasminogen activator. Look at that, activase. There it is, right? Activase, active vessel, active. There's so many ways to kind of remember that one. So thankfully, that one's a little bit on the easier side. Um, Human TPA, there it is. Look, it's just genetically recombined in order to mimic it. It's a TPA, right? again, actively dissolves clots. That's it. Um, and this is just basically referring to this right here. So it's just review. So we can move on. So there those specific time windows, right? It needs to be given within 12 hours for an MI, right? And it needs to be given within 3 hours of a ischemic stroke or a thrombolic stroke, right? So I know either ways, if the heart is having a heart attack, that's bad, and we want to directly affect that right now. Like we want to address that. But the brain, right? The brain, without even more than like I think 6 minutes, you start having severe brain damage without oxygen, right? Because of the ischemia. That's the reason why the window is so short for that one. They need like that needs to be immediate because once it's past those 3 hours, now it's case by case, and they're like, well, maybe give it, maybe not, because you can cause a lot of damage with these drugs because they're very strong, because they cause a lot of bleeding. This one is the most. This is the strongest. This is the big gun. This is the most dangerous drug to give because even doing little things can cause you to bleed severely with this drug. And it makes sense, right? Because this one actively will break down any clot made. So you really won't be able to clot, right? So there are risks, there's pros and cons. Obviously, if a person is having an MI, you want to address that as soon as possible, but at least there's a bigger window because there's a little bit more of a room for, as messed up as it sounds, a little bit of room for error compared to brain damage because you can't really undo brain damage. And I would imagine I mean, they're both difficult to treat, but I would imagine it's just a little bit, like by one little tiny percent, easier to treat heart related problems than a full on brain tissue death. Because once you lose that brain tissue, you can't ever make it back, right? So that's the reason why the windows are a little. This is a very like dire drug. You need to take this as soon as possible, right? There it is. Look, avoid any injections really because it can cause bleeding, right? Makes sense. But this one just really, really puts you susceptible to bleeding. So, adverse effects, right? Bleeding. Wow, what a surprise. Intracranial bleeding could occur. And that way we could kind of remember, right? And that's why we'll use the intracranial bleeding with the different contraindications, right? Our body is often, most than not, like it's very possible that, especially older people, sometimes in our body we're injured, but we don't never notice it, right? Because we're clotting normally, we have normal homeostasis, we aren't bleeding, we're not having an internal bleeding, right? Like we're not having any of that, right? Because our body is healthy and it can properly respond, right? So it's sometimes likely, like, if anyone has ever heard of a TIA, a transient ischemic stroke, right? That's like a little clot that occurred and clotted for a moment, or like blocked bleeding or blocked circulation for a moment, but then went away. So it mimics stroke signs, which is still something to watch out for, but it's not a full blown stroke. So I would imagine there are like just like little ischemic strokes in the brain, there are little tiny bleeds that occur in the brains, right? Especially if patients have like aneurysms, right? Like the vessel is getting weaker, so it can balloon out and pop. Sometimes that can happen, right? So if you have these little bleeds, maybe they won't be noticeable as much, right? Maybe you'll have a headache, maybe you'll have like these little tiny bleeds and you won't notice them that much because they're almost negligible, right? If you were to have any trauma, any type of like past history of bleeding in the brain, if you were to take this drug, even if it's very recent, right, because it's still healing, because brain tissue is very sensitive, it can actually reignite bleeding and cause that increased intracranial bleeding, which makes increased intracranial pressure and then can cause a stroke, but in a different way, right? So that's why that's something possible. So just think very crazy side effects for this one, like very excessive bleeding, and possibly brain bleeds too, because of just what is going on inside, because it really will prevent any type of clot from happening. Ecchymosis is just a very fancy word for bruising. Hematomas is a lot of bruising or a lot of blood collecting in on tissue that's creating a mass. Epistaxis is a very, very fancy term for a nosebleed. And then there's our contraindications, right? Internal bleeding. Obviously, if they're already bleeding, why would you give them something that's going to make them bleed more? History of stroke or head injury, right? Because we talked about that, right? If you had a past head injury and maybe you never notice it because our body, like even little things will cause damage, but if we're healthy, they will fix it. But if we're not, they won't, and then now we're having full on bleeding. Um, and that's referring to even up to past 3 months, recent trauma or surgery, right? You're healing, you're not fully closed up, and then now you just gave a drug that's going to cause a lot of bleeding to occur or like no clotting, right? So now you're going to bleed more. And then severe uncontrolled hypertension, I would imagine because of if you have high levels of pressure, right? And then maybe connect the dot too with like the patient having a weaker blood vessels, and then the blood vessel balloons out, and then it pops, and then now you're having internal bleeding again, and now it's what if it's in the brain? Now you're having a stroke because of a hemorrhagic stroke, and now that's causing pressure and so on. So it's like a big domino effect. So probably not for that one, right? Because more pressure will put things likely to rupture, and then eventually if it ruptures you're just going to bleed a lot and bleed out. Intracranial neoplasm, a lot of brain stuff, and then atriovenous malformation, again that's all related to blood vessels. And then finally this last little piece right here, so we have our drug-drug interactions, right? I didn't even highlight this stuff because it's just a repeat. Use it with anticoagulants, use it with antiplatelets. It increases your risk of bleeding. And we can break it down just by saying, right? Alteplase will break up any clot it finds, right? Um, Antiplatelets will prevent platelets from even clumping in the beginning, and then anticoagulants will prevent the signal to clot from beginning at all. So that's three different things going on at once. At that point, like you can basically say your ability to clot has been erased from your body. Like you can't clot at all anymore. Like even little things will kill you. Like a freaking little scrape can just keep bleeding without any sense of control because you've lost the ability to. So now we've kind of broken down what that is and why maybe it wouldn't be a good idea to give it for people ongoing with that unless it's that necessary. Makes sense, right? It's going to increase PT and PTT, right? Again, it's all relating to our ability to plot to clot. If you're basically removing that, it's going to be harder for you to clot. That's why it's referring to that. And then here it is again. Feverfew, our 4Gs and fish oil. Where did we have fish oil? Plavix, our antiplatelet. That's it. There is no specific treatment for overdose. Just hopefully you don't bleed out. Just give a bunch of blood products, and that's it. Um, and then this is our last slide, which it is, right? This, you guys remember that blue highlight? Ooh, look at the blue highlight. Ooh, that means it's an anticoagulation drug, right? This is just referring to, what did we say anticoagulation drugs do? They mess with the signal to form coagulation. We said coagulation is caused by a lot of different factors, right? Factor one, factor two, A, B, C, D, whatever. I don't know what they are, but one of them is factor XA. That's what I know. And factor XA inhibitors are the ones that end with XABAN, Zaxaban, or whatever the heck you call it, right? So we have apixaban, and we could kind of think about it like this, right? We're banning XA, right? Factor XA is banned, so you're not using it anymore. So you won't have factor XA. Now you won't be able to clot because it's an anticoagulant, right? So apixaban, we're banning factor XA, and it does the same effect, right? If you remove, what did we talk about in our lipid um, like slides, right? If you take off one piece of the puzzle won't look right. Or you take off a piece of the machine won't work right. So you take that off, right? Because this is one factor of like the 20 different factors to clot, and now it's missing a part and it can't do its job. So this is the same thing. The nice thing, less side effects, less diet restrictions, right? There were certain diet restrictions for the other um, anticoagulant drugs or antiplatelet and so on and so forth. So you need, these have less diet restrictions, less side effects. I mean, in the end though, all of these, their side effect will be bleeding. you can't get rid of that because there's no way you can have an anticoagulant drug and not bleed. That's kind of impossible. There's no real markers again because what do we say? It's just really your PTT, uh, your APTT, your PLT, and stuff like that. So there's not crazy stuff. And obviously, you need to stop taking these before big procedures, right? Because that can end up causing a lot of bleeding out. So I guess when it comes to procedures, they're more just referring to in the past slides. They're just the because you guys remember how we had a lot of these. It's given for this treatment, like this surgery, this heart surgery, blah blah blah. Maybe it's after the surgery or something like that. Perhaps I'm not too sure. In preparation to it, or maybe it's ongoing. It's a little hard because it doesn't fully clarify that, but at least we need to know when you have factor XA banned, right? Apixaban, rivaroxaban, right? Xarelto. Um, you need to pause before any procedures, just like how you need to pause with like Plavix, like pause before 5 days in the for any medical procedures or surgeries. And that's really it. Um, Hopefully it was clear. Hopefully things got situated, and we'll just move on to the next one. And that's it.